Are we live?
Working on it. Yep, now we're live.
All right. Good morning, everyone. Welcome to the Insurance and Pharmaceuticals Subcommittee of the Health and Government Operations. Anyone who provided feedback on in the original hearing, whether it was oral, written, or both, was invited to participate in this subcommittee meeting. Since we had a hearing on these bills that we're going to be talking about today, should be looked at as a work session. So what I'll be doing is asking people to speak specifically around new information. The subcommittee members will be given the opportunity to participate in dialogue. If you're not on the subcommittee and you have information that you would like to share, please make sure that I know by using the raise hand function in the reactions tab. Lisa Simpson, our counsel, is going to provide us with information about the bill, and then I will give the sponsor an opportunity to speak, and then I will ask if anyone has additional information for us, and I'll ask for questions from the committee. We are doing 3 bills today. It's my expectation that we will not vote on all of them, and that we may be just getting some information. The order of the bills are HB 162, HB 123, and HB 303. With that having been said, we're going to start with HB 162, Prescription Drug Affordability Board, Upper Payment Limits and Reports. Lisa, tell us what it does.
House Bill 162 repeals the requirement that the Prescription Drug Affordability Board find that it is in the best interest of the state to set upper payment limits before it drafts a plan of action to submit to the Legislative Policy Committee. The bill also requires the Prescription Drug Affordability Board to set upper payment limits on specified drugs by February 1st, 2022, and it changes several the deadlines for several reporting requirements.
Okay. Thank you, Lisa. Delegate Ivey, want to talk to your bill for a moment?
Absolutely. Thank you, Madam Chair, and to Council and the entire committee for the work that you all have been doing in looking to lower the cost of prescription drugs, not only this year, but years in the past. And really, a historic step forward was made by our state by creating this board that I'm looking to make a small change to. And specifically, the genesis of this bill, of course, came from the COVID-19 pandemic, seeking to find ways to accelerate relief to individuals and also ensure that in the long term, we continue doing everything we can to lower the cost of prescription drugs. We know that the coronavirus crisis will all be vaccinated in a year's time or so, but the economic impacts that this virus has caused is going to stay with us and so many members of our community and well into the next decade. So again, whatever we can do to lower the cost of prescription drugs, that's the goal behind this piece of legislation.
Making me cold.
Thank you very much, Delegate. I appreciate your commitment to that. Sure. Thank you, Delegate Carr, for putting yourself on mute. Is there anyone in the room right now who has additional information on this bill or would like to provide information on the bill?
My dear friend, the minority leader.
Seeing no, and I wanted to speak to the bill.
Delegate Kipke did have his hand up. I'm not sure.
Delegate Kipke? I'm sorry.
I'm happy to speak or defer to the chair if you might be about to say what I'm thinking.
Well, okay, I appreciate the deferral and I'll do it because the Prescription Drug Affordability Board is near and dear to my heart as the members who have served, and when we created the board, I was active in the creation of it. And so while I appreciate your intent very sincerely, Delegate, I worry that it's sort of circumventing the discussions that we had around what the board could do and would make it a challenge for us to make sure that the board could continue in the way that we designed it to. It hasn't had time to do its work yet. With any luck, we'll get the funding mechanism for the board in place this year. We just got an executive director. There's a tremendous amount of research that will need to go into the work of the board. This cannot, the deadline of even, a year from now would be way, way ambitious. So I'm asking if you would consider letting the board get to work for a year or two before we make requirements around the kinds of setting the upper payment limits. I see Delegate Kerr. Let me ask Delegate Ivy if you'd like to respond to my comments.
Oh, well, certainly. The subcommittee, your standing committee, you all will be the ones to make these final decisions. And I just want to be a part of the progress as we look to move forward to lower the pricing of prescription drugs. Of course, you all have been working on these issues for some time now. And so I will always continue to try and, be on the frontier of some of these, progressive policies that we're looking to push. But I am also mindful of some of the other constraints.
Thank you very much, Delegate Ivy. Delegate Kerr?
Thank you, Madam Chair. Delegate Ivy, I too appreciate the intent of this bill and your dedication to lowering the price of prescription drugs. But as the chairman said, it does appear to work at cross.
Oh, okay.
It does appear to work at cross purposes to the intent of the Prescription Drug Affordability Board, and so I would move unfavorable.
Okay, so if I have an unfavorable.
I'll second that.
Any further discussion on the bill? Seeing none.
I've never seen an unfavorable go down so gently. People must really like Delegate Ivy. That's all I can say.
Well, Delegate, I think that we truly appreciate Delegate Ivy's commitment and intent around this. So, it's the right thing, right way to do it. Will there be any opposition to the unfavorable? Okay, I have one opposition, two, okay. Oh, Delegate Kerr, you can't vote against your own motion. I'm just asking for opposition now.
Yep, I forgot to lower my hand.
Okay, all right, then, while the motion is unfavorable, Delegate Ivy, you have the opportunity to withdraw it if you'd like. So, we can talk about that offline if you'd like. Okay?
Well, I want to thank the committee for the work that y'all have been doing, for your commitment on this and so many other issues. And truly, I look forward to working in partnership with you as we move forward.
Thank you. And we share that looking forward. So thank you. We are now, so the work on 162 is complete. We're going to move now to House Bill 123, which is likely to take a little longer and because there has been a tremendous amount of work on this bill. So anyone who is involved in, has a role, has information for us on 123 is now being led into the room. And are we there? I only see delegates at this point in the room.
Give me 1 second because AJ had class, so it's just me letting people in.
Okay.
Yeah, give me a second. It's just taking me a little bit
Okay.
because it's just me.
We're all flexible. The technology is working today. We are all happy about that. So. while we're waiting for folks to be let in, delegates, subcommittee members, I think that you have, you should have a document that was sent out to you by Lisa on Monday, I believe. That's a reprint of the bill, and we're going to be going through that. So it's good to have it handy.
Okay. Yeah,
Okay, now we're getting folks in. Okay. Okay, this is looking more like it. Do we have everyone? Bridget, do you think we have everyone? And do we know if Delegate Pena Melnick is going to be here at all? Did we hear from her?
Yes.
Yes, we heard that she is coming.
I know yesterday she couldn't make it and sent 2 people, but then I don't see their names today.
Okay.
I know I haven't heard from her.
Okay. She has her own subcommittee meeting right now, so
I can find out. Give me a second.
unlikely. Okay.
Sorry, can you hear me? This is Allison Horseman. I'm from Jocelyn Pena Melnick's office. She's not going to be able to make it today, and I am a legislative intern here in her place.
Okay. Well, thank you, Allison. Thank you for being here. Did she send you with information, or are you here to observe and take information back to her?
I'm here to take information back to her, but I do have a good understanding of the bill, but I think Jennifer Witten might be the best person to talk to about it.
Okay, wonderful. Thank you, Allison. We appreciate you being here. So, House Bill 123, Preserve Telehealth Access Act of 2021. We are going to walk through this, the reprint of the bill that was provided to you by Lisa Simpson. At the conclusion of that walkthrough, we're going to hear from the major stakeholders, including the Hospital Association, the insurance carriers, the providers. Those are the ones to start with, and there may be others who want to provide information. We are not voting on this bill today. Today is about gathering information. We'll take about 25 minutes on this bill, and then we'll stop and know that we're going to be coming back to it. There are several other telehealth bills that we're going to be hearing, and part of our work will be to see if there's overlap, to see if there's ways to combine them, if appropriate. So know that this bill is still in progress, but it's a very important bill and a very complex bill, and we want to make sure that people have the information going forward. So with that, Lisa, I'm going to turn it over to you.
Great, thank you. House Bill 123 expands the definitions of telehealth for both Medicaid and private insurance. The bill requires Medicaid to provide healthcare services appropriately delivered through telehealth to program recipients, regardless of their location at the time telehealth services are provided, and allow a distant site provider to provide healthcare services to a recipient from any location at which the services may be appropriately delivered through telehealth. Carriers must reimburse for a covered service appropriately provided through telehealth on the same basis and at the same rate as if delivered in person. A carrier may not impose as a condition of reimbursement for a telehealth service that the service be provided by a provider designated by the carrier. In the reprint, the amendments start on page 4. This amendment is clarifying that the definition of telehealth for purposes of Medicaid includes audio-only health services and does not include telephone conversations that do not result in billable healthcare services or that do result in an in-person fee-for-service visit. The second amendments start on page 5. They clarify that MDH is required to get any federal authority necessary to implement the Medicaid provisions of the bill, including any amendments needed for 1115 waivers and the state plan. There are amendments on the bottom of page 5, top of page 6 of the reprint that make the same definitions, or excuse me, the same changes to the definition of telehealth for private insurance as was made for Medicaid. On page 7, the amendments clarify that a carrier cannot require a service be provided by a specific third-party vendor as a condition for reimbursement. And beginning on page 8, the amendments require the Maryland Healthcare Commission, in conjunction as appropriate with HSCRC and MIA, to submit a report on the impact of providing telehealth services in accordance with the provisions of the Act. The report is required to consider both audio-only and audio-visual technologies. The report requires analysis of the impact of telehealth on disparities in access, the differences in the take-up rates among different communities and patient populations, and the comparative effectiveness of telehealth and in-person visits on the total cost of care and patient outcomes. The report also requires a study on the alignment of telehealth with new models of care, assessments on the efficiency and effectiveness of telehealth and patient satisfaction, and a review of the appropriateness of telehealth across the continuum of care as defined in the Berenson-Eggers type of service codes, inclusion of clinic, hospital, facility, and reimbursement of hospital-provided telehealth, and the use of telehealth to satisfy network adequacy. The report will make recommendations on coverage of telehealth services and payment levels relative to in-person care. And lastly, the amendments add a 2-year sunset provision.
Thank you, Lisa. That's our starting point. I know folks have just had a couple of days to look at this particular document. So what I'd ask now is let's start with MHA. There's Jen. So we want to speak to this document as well as the overall concept of what you all would like to achieve in the bill.
Great. Thank you, Delegate Collison and members of the subcommittee. It's a pleasure to be here with you today. So just for starters, really the intent of the bill was to provide some predictability in terms of access to care post-pandemic. As many of you know, both the federal government and the state waived a number of restrictions in the use of telehealth during the pandemic, to really make sure that we were providing access to care to citizens throughout the state in a varied way of telehealth modalities. And so the bill before you really looked at some of those policies that were waived that we felt were really restrictive and would ensure that we continue to have that access. In particular, I can speak to some of the points, appreciate that many of the folks here today have been in some ongoing conversations around sort of working through this legislation. Our intent is to provide, again, that ability for clinicians to have different modalities to use to reach patients throughout the state who may have limited access to in-person care. And again, really making sure that we preserve, all of those clinical standards and scope of practice that we currently have in state law. So as we think about the bill before you in the reprint, if I can just add a couple of comments for the committee to consider. And again, can speak to some of the work that's gone into this. So as the first section, if we go to page 3, really no changes in terms of the language that was provided around distant site and originating site. Just want to remind the committee, those are important provisions. These are provisions that Medicaid has traditionally had in terms of restricting both reimbursement and access for telehealth services. We've been working with Medicaid prior to the pandemic to think about removing these restrictions. So these are good policies moving forward. And then we define who that health practitioner is. We also expand out some content around remote patient monitoring, knowing some of those modalities have been helpful in terms of monitoring patients' care, especially those who have chronic diseases.
Jan,
I think
before you go on, and I apologize, but I just think that a lot of the committee might not know what remote access care means. So if you could just take a second to tell us.
Sure, Delegate. So I think the easiest way to explain that are different devices and tools that are used to, say, monitor a patient's condition. So I think the easy example is somebody with congestive heart failure, where you may be monitoring their blood pressure on an ongoing daily basis and their weight intake, and you may identify that their readouts, if you will, that go to the provider are out of kind of normal bounds for that patient. And so the provider would be then notified that there needs to be an adjustment in treatment. And they could read some of those measures and then make some of those active treatments. And so it's using sort of those tools real time to really monitor someone's condition. So that's what remote patient monitoring is referring to.
Okay, thank you very much. Sorry to interrupt.
You're welcome. I think where we get into probably more of the conversation is here under how we're redefining telehealth. And so as the bill laid out before you, telehealth, we have now included the definition of allowing audio only use. Lots of conversation around how we use audio only consultative services. MHA in ongoing conversations really tried to work on putting some kind of parameters around what we mean by audio only use, meaning that these aren't just follow-up conversations or brief conversations about your lab results, for example, but these are consultative services. This has been a very valuable tool for many providers. You may hear from some of them, to reach individuals who either don't have technology for video audio only or have limited internet access. And so this has been a very valuable tool. MHA did offer some of the language that you see here in the reprint in terms of what audio only would include related to a billable service and what audio only does not include, except for I will note that there was additional language added in-person fee for service. So audio only telephone conversation that results in an in-person fee for service. I think it's important this committee hears from other providers. We are concerned with this. Again, you may have a consultation with a patient and there might be a desire later, there may be a need for a follow-up in-person visit for a variety of reasons. And by adding this language, this would make this ability to use this tool, I think, very challenging for providers. So we would ask the committee not to include this restriction on the fee-for-service language. Following that, if we go to page 5, Lisa spoke to many of the amendments related to the program. I think there was just general consensus to allow Medicaid the ability to apply for the appropriate waivers. We did note that in some of the language we provided, we did have a cross-reference to COMAR 15-105.2. That might just be a technical issue. That is current law that outlines a number of programs and providers that Medicaid currently approves. So we think that cross-reference is important here, but that I think we see as more of a technical issue. Then moving on from that, you see the fee-for-service language included under the insurance articles of reference. I spoke to that up top under the definition. So again, I think we need to have some more conversation around the implications for adding that restriction. And then if we go to the evaluation language on page 8, I just want to acknowledge Ben Steffen and many of the carriers and the providers. We had many discussions around what this evaluation component could look like. I think we are moving in the right direction and appreciate bringing in some of the other agencies that have oversight or would have a perspective in this area. So MHA does not have any additional comments on the evaluation language. And then the last section I would note, and I'm going to be, I think this may have been an error, but this is on the sunset provision. So if everyone looks at the last page, section 4, this would be the sunset provision. We're fine with this language, but I don't think this was what the committee intended, because the sunset is June 30th of 2023, which is about 102 years from now. If the committee should decide that you want to preserve that date, MHA is fine with that sunset date. I don't think I will be here to advocate on that at that time. However, I don't think that the committee and some of the stakeholders working on this, that was the intention. So what I'll say to the sunset date is that is a compromise. We see that from the MHA's perspective. I think what's important is that for us, if there's a sunset date included in the bill, that we would ask the committee to consider narrowing that scope just to audio only, where there has been probably the most debate and discussion, and the reimbursement, not the rest of the provisions, that there was agreement with the rest of the stakeholders as it relates to distance site, originating site, and some of those provisions. So would ask the committee maybe to tease that portion out and have the evaluation really speak to kind of the audio only and the reimbursement aspects of the bill. So thank you, Madam Chair, for this opportunity to share our thoughts. I know you have many other stakeholders that the committee would like to hear from. Happy to answer any questions.
Thank you very much. You'll probably get questions next week. So the payers, Debbie, Matt, who would
Sure.
like to speak to it?
Matt, if you want to do it, you can. Otherwise, I'll jump in. What do you want? All right. You can jump in with me. So I would say that we really do appreciate the amendments, and having worked on this for months now, we think this is getting a lot closer to what makes sense. I will react a little bit to, I think, what Allison was talking about. We absolutely think a study was imperative, and we're really appreciative that the study is in here. We think it looks at all the right elements. I think that Lisa did a great job pulling the elements that the provider community thought were really important, and also was true to what Ben Steffen from the MHCC put together from his determination from all the weeks of meetings with all the stakeholders of what he thought was important to have in a study. So I really applaud you, Lisa, for putting all that together. I think it's a really excellent study, and it's going to move us forward in the state to what's really important as how we develop a telehealth framework going forward. That's because of that study. We also think that the sunset is really important, and having a sunset for 2 years will give the MHCC the opportunity to analyze data that from what happened during the pandemic and then after the pandemic. And we think it's really important that data can be looked at once we get back to whatever we call normal after the pandemic, and that we see what's happening in terms of quality, in terms of cost, in terms of access for all these modalities. Where I would say we disagree with Jen's suggestion is that while we don't think the entire bill should sunset, which we agree with her, we do think that part of this, what is being looked at in the study is what is the value for telehealth services and what's the value of audio only services. And to not have those two pieces sunset is a mistake. Now, when I say that, please don't hear me wrongly that we should take out telehealth from the law. The law has been there for 8 years. The law as it was should stay there. Carriers must reimburse for telehealth services like they always have. But what is new to this bill is the inclusion of audio only services and the inclusion of payment parameters for telehealth and audio only services. Those two pieces, which are new in the law, should be sunsetted, and we should come back, all interested parties, so the legislature can make a determination based on the analysis that will be done now by the MHCC, MIA, and HSCRC, with all interested parties involved, as to what makes sense moving forward on the new components of the law for audio only and for reimbursement of telehealth services, because we'll get a lot more information as to what was the impact on quality, what happened around the state, where it was most effective, what services was it most effective for what populations. And so I think we're going to find that this study will make a big difference. And so we would ask that exactly the way, or at least those two elements, I'm not sure how Lisa drafted it, if those are the two elements that would sunset, but we would ask that they sunset. Two other things that I wanted to add. One thing I would like to talk about in the draft is that when we talk about audio only services in particular, and maybe I will ask others to comment on this for telehealth services, should the definition be for an established patient? I was listening to the testimony in the past, and I believe that there were some that say, especially for audio only, if you've never met the patient before, you've had no relationship with that person, is it really appropriate that you should start being able to have phone calls with someone that you haven't seen and know nothing about? And I don't think that in the definition it speaks of established patient. And so I'm asking for us to have that conversation. That may be something that is valuable in this bill. I think it is. And the last thing I'll just raise is, I think Jen mentioned about that it would not apply to an audio, this bill doesn't apply to an audio only call that results in an in-person fee for service visit. I think that's really something that we should also, you need to discuss. I think the goal there is that we don't want services to be duplicative. You don't want a phone call and then the provider says, you know, I'm not really sure, come on in. So then we've paid twice for the same thing. If they had gone to the office visit, they would have gotten a full service and consultation and an effective result from the provider. I think that's what that language is, and maybe it needs some tweaking that is consistent with what Medicare does right now. I believe that they say that a phone call should not be tied to a service that had been performed 7 days prior or 24 hours going forward. And that's really the goal of this, is so we're not doubling the service. We're actually trying, the goal here is that you're going to find a quality service that could replace the in-office visit because it's just as effective. So maybe that needs to be tweaked, but I would suggest that that should something that should stay in. And I'll stop there. Thank you very much.
Matt, did you have anything to add?
Just one or two quick things. I think Deb had her Wheaties this morning, so I don't really need to go through it. She did a great job. But I just want to highlight the importance of the study and the study to incorporate telehealth and audio-only services. The bill is introduced is wide sweeping health policy changes. And I think that the study sort of speaks to what we've been talking about since the beginning, is that is really, really important before we make significant health policy changes, that we have the study to be able to analyze what happened prior pandemic, what has happened during the pandemic, and what has happened after. Don't get us wrong. We are still in the midst of the crisis, and we are seeing unprecedented utilization of telehealth services, which is fantastic. And in the beginning of the pandemic, we were doing anything we could to drive people towards telehealth because we wanted them to stay home and to control the spread. And in a lot of ways, we're still doing that. But to make changes that would capture what's happening in the midst of an emergency and not realize the impact of the entire healthcare system and the costs related in the long term, I think would be inappropriate. So we cannot thank everyone enough. Thank you very much, Lisa, for the reprint. And we're really looking forward to seeing the results of the study so we can make appropriate changes at the time.
Okay, thank you. Kim Robinson, do you have something quick?
Yes,
Okay.
Just one point. Debbie made the point that she was trying to hit all the points. So just like Matt just highlighted the study, I just want to highlight one thing. And say, one, thanks to you, Madam Chair, for taking a look at all of the amendments and putting something together to try to move us to compromise. Thanks to the sponsor and the other stakeholders for the work along the way. I just wanted to go back to Deb's point on why we do think that that language around an audio-only visit that results in a fee-for-service in-office visit is important. As Deb was trying to highlight, it's about utilization and the purpose of why we're recognizing telehealth. It has been a godsend in the pandemic because it has been a substitute as it's intended for in-office care. And so what we're looking for is language that makes clear that the goal is not to be duplicative. It's not to increase utilization and therefore increase costs. When a service should have been in office, then it shouldn't be shifted to telehealth. And so the goal, and what I think most providers have done effectively, has been to triage a patient and determine what is the right mode to address their need. Do I need to see you in person? Can we do this by video? Can we do this by audio? And if audio is not appropriate because I need to lay eyes on you, then it has to be video or in office. And understanding that, the goal is to say carriers and patients also, because patients are paying for this too, they will be paying their deductibles and copays, shouldn't be paying twice for a service that should not have happened via telehealth and should have been in person. So there may be a better way to say it, but I think that that concept of understanding that the goal is to make this a substitute for in-office and not adding to the service is what's really important. So thank you.
Right. Thank you. So I have a number of providers who've asked to speak. So know that I'm going to give you that opportunity, but I want to start with the MIA. Michael, you.
Sure. Thanks, Delegate Colson. I just wanted to highlight two things. The first is the MIA did submit a letter of information on the bill, highlighting some of the intent regarding subsection E on page 7 of the reprint. Our concerns have been addressed. Those changes make the intent clear. We don't have a problem with that anymore. The initial amendment we saw to the bill didn't explicitly include us in the study. I just realized that as Jen was going over the bill for today. I do want to take one more look at it just to make sure that the areas where the MIA, does have authority, are just drafted properly so that, when we do work with MHCC, that analysis is done correctly.
Okay.
That's all I had to add.
Great. Thank you, Michael. And if the providers will give me one more indulgence, I'm going to ask Mr. Stefan if you have any information, any further information. Thank you for putting the work together to create the study language. So I appreciate that.
So thank you, Chairman Cullison. I want to be pretty brief today, but I do want to make the point that the verdict is still out on a number of questions regarding telehealth. And this comes from an executive director of the Healthcare Commission, who over the last decade has been a voice in the wilderness in promoting telehealth. We think that although there was an explosion of telehealth during the pandemic as a result of substitution for inpatient services, we really do need to address the question that the payers and providers are most interested in. Is it additive or is it a substitution? Ideally, everyone would applaud substitution. Cost becomes a concern when it's additive. The quality measures for telehealth are still really in their infancy. We have significant questions about that, where it's appropriate, what type of patient it's appropriate for. We need to get better information on that before we cement this into Maryland law. And finally, safety and quality are certainly big issues that before we establish parity for any service, we need to have better evidence. I can't think of a better organization in Maryland government to take this study on. The 15 members of the commission include 4 practitioners, 3 of whom deliver telehealth services in the course of their work. It includes the vice counsel for a leading health insurer, several consumer representatives, several of them who are heavily involved in advocacy for orphan drugs and conditions that are extremely rare. And then several policy experts, one from RAND Corporation, Her colleagues at RAND are the leading experts on the diffusion of telehealth during the pandemic. And a second who had served in the federal government as head of the Assistant Secretary for Program Evaluation. So the commission is very interested, riveted on this, recognizes it's important, but thinks it's important to gather the appropriate evidence before we go forward.
Thank you, Mr. Stefan. Okay, providers, I'm going to be calling on you now, and I'm going to ask you to be concise and as well as compelling, and we're only going to hear from the providers who have their hands up now, which is about 7 of you, with 6 plus HSCRC, and then we will carry this bill over till next week. So I'm going to start with Ann Seacott.
Thank you, Madam Chair. Thanks to everybody. This is, feels like things are coming together. But I did want to react to a few things. When we talk about how, this bill will open up so much, the fact is the pandemic forced us to open up the doors as wide as they can go. And so the decisions being made related to this bill are how much are we going to close those doors? And so, I think we want to make sure that some of those decisions, just are very well thought out, and have that reflected a bit, I think, in any kind of study language. I do want to say that we also would urge, coming from the behavioral health provider world, we would urge that that we not put clinical practice into statute. So when we talk about things like, should a first visit be in person or not, please keep in mind that may be a different answer for different kinds of services, for people with different kinds of diagnoses. And so we think that's a level of detail that is not appropriate to put in statute, that we believe that, we have to have some ability to trust our clinicians as well as consumers when it comes to deciding, what might be the best visit for them. And then the last thing I'll say is we have very much concerns about the language, and we understand, tweaking will be happening. But the idea that an audio only visit that leads to an in-person visit, I heard loud and clear, we just want to make sure things aren't duplicative, but you might not know when you're on the phone with someone that what they do need is to come in person until you've actually spent that time between the clinician and the client. So thank you for all the work, and we're looking forward to finishing this product.
Thank you. Thank you. I'm going to go next to Jeffrey Grossi.
Madam Chair and members of the subcommittee, thank you for advancing this important conversation. I echo the comments from Jen Whitten at MHA and Ann Seacott. My comments are related to the top of page 6, telehealth does not include, and it's the second bullet. And you've heard a lot on this. I'm going to play it out for you with an example. So we have a crisis walk-in clinic. Person walks in, gets a crisis evaluation. It's a billable service, gets referred to an inpatient bed or next day program, which is another in-person visit, all covered, all billable. Virtual crisis center, crisis walk-in clinic, somebody calls in, same process, just not there in person, billable service for the crisis evaluation, and then gets referred to an inpatient visit, whether it's an inpatient bed or a day program or what have you. My reading of this would say that the telephone conversation would not be covered, even though it's the exact same service they'd be getting as an in-person. So I'd implore you to take a look at that, and I'm happy to answer more questions or get you in touch with our doctors who can speak to that as well. And then I'd also implore you to maintain the audio only portions of this bill to the extent possible, because they really benefit the most vulnerable Marylanders that are out there. And that's all I'll say on that. And thank you for the time.
Okay, so now we've heard from 3 people about the question around, audio requiring in person. So If you're speaking specifically to that, please say me too. We're hearing you. So we're going to go to Lori Doyle.
Hi, Madam Chair. Lori Doyle here with the Community Behavioral Health Association of Maryland, and thank you for allowing me to speak. And I will say me too on the that provision with the telephonic and then a follow-up service in person. I guess what I'd like to really focus on, because it hasn't gotten a lot of traction or at least a lot of conversation, is the remote patient monitoring piece. So RPM is something that is a game changer for us. In the community behavioral health field, we have been in a workforce crisis long before the pandemic occurred, and we will be in it again when the pandemic ends. And so to the extent that we can use remote patient monitoring to be, in essence, workforce extenders, we should be looking at that. Right now, the state is very restrictive in the use of RPM to 3 different diagnostic categories, COPD, diabetes, and I think it's congestive heart failure. And it doesn't cover any of the apparatus in terms of reimbursement. The target populations for this are people who have chronic high-risk conditions, and that certainly covers those with serious mental illnesses. We in the field are using some remarkable technology called Medherent that measures medication adherence, and we all know if you're not adherent with medications, ED visits and other bad things tend to happen. And so this allows us to focus our staff efforts on those people who are having a problem, not on the people who are doing well. So we hope that the study language would be beefed up around a remote patient monitoring, and that we would actually encourage the department to extend the use of remote patient monitoring. I think it's probably utilized more in the commercial market than it is in Medicaid. So thank you for the opportunity.
Great, thank you. Going to, let's see, Lori, Pam Casemeyer.
So I will say me too, also on the issue of the audio only versus and then in person. There is a claims adjudication process where you have to prove the clinical services you've provided. So we have a lot of concerns with that. I'll stop with me too. And also talk and reiterate much of what you've heard from the rest of the provider community. I think we're all having our hands up because this is very broad in its impact on the provider community, particularly small providers, rural providers, federally qualified health centers. This is not a big institution versus small provider issue, or a big institution versus carrier issue.
Thank you, Pam. We're going to Megan Renfro, HSCRC.
Good afternoon, thank you. I wanted to speak to an issue that that hasn't been brought up. Over the past 2 weeks, HSCRC had been working with MHCC and had some conversations with MHA about the reimbursement language that's on page 6. We have 2 interests in that language. One is with protecting HSC's unique rate setting authority around hospitals and flexibility there. The second, and actually more important to our commissioners, is protecting consumers with respect to facility fees. During the pandemic, we've had a policy that clinic fees can only be charged for telehealth for providers who cannot bill. And I want to note, HSCRC only regulates certain spaces. So the vast majority of telehealth is happening outside of spaces we regulate. So we're just talking about our domain. But we've limited when clinic fees can be billed. And so we'd like to have the ability to continue a policy like that in the future and just generally have the flexibility to set policies over the rates that are in regulated HSCRC regulated spaces. There was some language in MHA's version of the bill from last week that was pretty close for us. And so I'd love to have the opportunity for us to continue to work towards getting to something that works.
Okay, thank you.
Yeah.
Ellen Weber.
Thank you, Madam Chairman.
the Legal Action Center on behalf of the Parity Coalition has not been part of these conversations, but I would like to thank you for putting in a placeholder at the beginning of your discussions with regard to the additional bills that will be heard by HGO today, and that will then be, we hope, part of the ongoing conversations. There are very specific provisions that we think are important with regard to the coverage of mental health and substance use disorder services that we think would help firm up those standards within this bill. There are some additional consumer protections that we also think are important. So appreciate the opportunity to raise those after the hearing today in HGO.
Great, thank you. Karen Kutrinik.
Thank you, Delegate Carlson, and thank you, the committee. I am representing the Board of Professional Counselors and Therapists, and we unanimously are also concerned about the audio only. And we understand during the pandemic it's necessary, and even we don't know what the new normal will be, but for it to go into just audio only, we're concerned about like the standard of care. Therapy, to really do therapy, it's very intimate. The nonverbals are really important. I think I'm speaking to you as a government employee who works in a therapy agency and who's been doing telehealth since March. And of course, all the other board members are doing therapy telehealth too. And it's possible to do with the video, but with just audio, I don't see how you can get into like really deep work. I can see audio being a stopgap measure. I can see audio being necessary in a really rural place where there is no access to telehealth, but to say that that would be a way to give therapy is very concerning to us. It's, I'm trying to think what else that's important to say. Therapy, like with when you were talking earlier about medical, like somebody calling with like lab work or information about medicine, that's a different kind of phone call. Therapy is not superficial, it's really deep, and it's about changing patterns inside of you or between other people. So example, you could never do family therapy on the phone. That would be actually impossible, or couples therapy. So we think that's so broad. We invite you to consider that for those kinds of therapy, it would really not be, it would not be, in our, it almost wouldn't be ethical because you couldn't give the right treatment. Thank you.
Thank you. Going to Stephanie Clapper.
Madam Chair, Stephanie Clapper from Maryland Citizens Health Initiative. I just wanted to emphasize from the consumer perspective how important audio-only telehealth has been under the pandemic. It lets people like older folks who don't have access to broadband or to devices that you would need to include a video component to telehealth to access it, folks in rural areas, a lot of Black and people of color in Maryland. And even after the pandemic is over, I think that a lot of the benefits that folks can get from it, it's really important to consider that. Transportation can still be a huge problem. There are disparities by disability. And I would hope that for any report that the voices of the consumers who benefit from audio-only telehealth would be part of that. I noticed that so far none of those folks have been here today to speak, and it might even be difficult for them to access this kind of way to provide input, just because of the levels of difficulty when you don't have access to those internet resources. So I just want to emphasize for consumers how important audio only has been.
Thank you. Laura Hale.
Thank you. Good afternoon, everyone. Laura Hale with the American Heart Association. We are very supportive of the Hospital Association's efforts on this legislation. Our one piece, just overall with both of the amendments and language to that, is our concern about the sunset at the end of the day. 2 years is not a lot of time, and we know that these services will all be needed in the long run. This is not something that goes away even after the pandemic. There's been a long need for continued coverage for audio only and others with this, especially for our representatives, for those with stroke and others who have difficulty getting out of the home. That doesn't go away with the pandemic. And so we want to make sure and would really encourage the body to not adopt the sunset language and to push forward, because this change is a long-term and I think a very effective change for the health of Marylanders. Thank you.
Thank you, Laura. But and I'm going to be clear. I want everyone who's listening, the sunset does not mean necessarily the services stop. It means it's the end of the period where we're studying it. And my experience in my 10 years in the legislature is good programs that are working, their sunsets are removed after we've looked at them and determined that they're working. So the sunset does not mean they're stopped. It means that that's the period where we decide that they're not working and we need to make some changes, and here's some changes we need to make, or yes, they're working great and we're going to keep them going. So just to be clear what the sunset means. Okay, I have Jacqueline Stone.
Thank you, Delegate Carlin. My name is Jacqueline Stone. I'm with Kennedy Krieger Institute, and Kennedy would like to say that we want to ensure that the population that we serve, those with intellectual developmental disabilities, are ensure that they're included. We view Maryland as our state, and we have found that particularly families from Western Maryland, Eastern Shore, Southern Maryland have really benefited from telehealth, and that they've been able to access the service where it's actually provided them with less travel time and less expenses. So that's been a huge benefit for families that would not have necessarily been able to access those specialized services that we provide at Kennedy Krieger. We want to ensure that the pilot that's proposed includes persons with disabilities across the state. We've already started as an institute in collecting data on who we serve by service and beginning to explore outcomes as it looks at the quality outcomes of the services that we're providing through telehealth. We're currently in about phase 2 of collecting this information and hope to provide some comparisons early on in the pandemic to now, as well as moving forward, in addition to adding some metrics as it relates to assessing quality. So we see ongoing telehealth as being a service delivery model that will not only enhance, but really augment the quality of services that we provide to the specialized population at Kennedy Krieger. So thank you very much.
Great, thank you. Robin Elliott.
Good afternoon. So I'm speaking today wearing the hat of nurse practitioners and community health centers and smaller providers, just as Pam mentioned. I just wanted to flag 3 things. I am a Me Too on modifying or removing that language that ties the reimbursement for audio only to not having an in-person service. I wanted to underscore the importance of both audio, video, and audio only reimbursement. I know we've heard a lot about audio. Providers are doing both, and having some predictable level of reimbursement is incredibly important. The provider world has gone through a number of upheavals. And so moving forward, as they are investing in their infrastructure to meet the needs of their patients, it's really critical that they have a sense of being adequately reimbursed. So thank you for everyone on this Zoom, because I know everyone's working towards that. And then finally, I just wanted to look at that issue of additive versus substitute. I think this committee hears so many bills about preventative services. I think it's the great promise of telehealth that in some areas we will be able to get more services to more people. Those will be preventative services and hopefully really avoid poor health outcomes and other costs to the system later. So thank you for your time.
Thank you. And our last person will be Kathleen Logren. Kathleen, are you?
Thank you, Madam Chair. I appreciate the opportunity to speak. And there are a number of issues in the bill, but I'm going to be very brief and speak to one in particular. Kathleen Lochran with AmeriGroup. We are a managed care organization serving the Medicaid program. And we have long been a proponent of telehealth. I think our concerns, like some others, are really around the audio-only provision. And with that in mind, the concern with audio-only, you've heard there isn't any language here that speaks to payment specifically. But today, facility fees are being paid by the HSCRC to institutions that typically would charge a facility fee for an in-person visit. And we believe that the state, under the Medicaid program, should not be paying facility fees. And I certainly appreciate the position and the efforts of the HSCRC with their language, but there are facilities that do not fall under HSCRC, and we think there needs to be language, at least in the Medicaid section of this bill, that would prohibit the ability to charge a facility fee for an audio-only visit. Thank you, Madam Chair.
Okay. Thank you. So we've heard a great deal of information today, and I really appreciate everyone's time and clarity around the issues. I think this has been really helpful for the subcommittee. We're going to take everything that we've heard, and the committee will have the chance over the next week to be thinking about this, and I fully believe that this bill will be coming back to us next week, and potentially with some discussion around a couple of the other telehealth bills that we're going to hear. So we are going to end the discussion on HB 123 and move to HB 303. And HB 303 is long-term care insurance prohibition on premium increases, sponsored by Delegate Stewart. Lisa, let's see, Delegate Stewart's in the room. And if there's somebody else, and MIA is in the room, that's good. And the provider and the payers are in the room. So Lisa, why don't you tell us what 303 does?
House Bill 303 prohibits a carrier from increasing a premium for long-term care insurance issued to an insured or entered into by a contract holder who is age 85 or older.
Okay. Delegate Stewart, would you like to speak to your bill and perhaps tell us about an amendment that you have?
I would love to, Madam Chair. Thank you very much, and thank you all for having me. This is my sort of first experience with the HGO subcommittee process, and wow, I have gained a newfound respect for the level of rigor and complexities in your work, to say the least. So my bill as amended is very simple. The amendments are very simple. Basically, they say that if a senior hits 85 and bought a long-term care insurance policy before the year 2005, then they can no longer get premium increase hikes imposed on them. The reason that we've decided to further narrow the bill to just those who purchased policies prior to 2005 is that's when these problematic policies were sold. As we talked about at the hearing, the height of this market of these policies that were very generous, but that were actuarially mispriced. Most policyholders purchased those in the late 90s or in the early aughts, and the insurance industry, to their credit, changed the policies by the mid-aughts so that they were correctly priced, and that the policyholders who have those policies are not being hit by these year after year after year increases. And so, essentially the idea behind the bill is to narrowly target it, focus on this one population of seniors that has been disproportionately hit by premium increases at no fault of their own. They did everything right. They bought these policies when they were younger. They tried to play by the rules. They had no idea they were going to be having to pay thousands and thousands of more dollars in just a few years for these policies. And we're hoping we can do this in a way that limits solvency risk to the industry, because we know that obviously they have to continue paying out claims. We get that. And I don't want them to become insolvent, but we think we've narrowed the bill down to such a small, just maybe a few thousand folks that have to reach 85. And even when they reach 85, obviously, just given the sort of morbidity math, the odds of them benefiting from this bill for years and years and years are slim. So the hope is that this bill will provide predictability and relief to thousands of Maryland seniors while minimizing any solvency risk to the industry.
Thank you, Delegate Stewart. Is there anyone else here who wants to speak to this, to the potential amendment to this bill?
Delegate Carlson, I would like to, if
Oh.
appropriate, in this fashion.
Certainly. Go for it.
First and foremost, I want to thank Delegate Stewart for sending over the amendment to me before today. I got a chance to run it up the flagpole, and as I said in my email response to him, I wish it had changed the position. It does not. The American Council of Life Insurers, America's Health Insurance Plans, and the League of Life and Health Insurers are still concerned with this bill, even with the amendment, for a couple of reasons that I sort of laid out at the hearing, but also. And I will sort of reiterate some of the ways that Maryland has taken action in this space in the last couple of years. In 2017, we passed a law that allowed rigorous rate review with the MIA, and if any rate increase is requested, it has to go through the MIA's actuarial process. There, you have to prove that you have adequate reserves to cover the losses. We passed a bill in 2018, the contingent benefit upon lapse bill, when any person that had could no longer pay their premium increases could start drawing down. That was a significant change. And last year we passed the amendments to the guarantee fund that would make sure that in the event of a company going insolvent, that other companies in the life insurance and health insurance space would make sure that they could cover the claims of Marylanders. You all have probably heard about Penn Treaty. It was a multi-billion-dollar insolvency a couple of years ago, which left a bunch of folks with nothing. The long-term care market is a complicated one. We've heard it in the past. It continues to be a policy, and a lot of it has to do with the insurance industry's fault. They just priced the policies wrong when they started with unlimited benefits. That's how it started, and that continues to be the challenge. Now, the folks that have those unlimited benefit legacy policies are shrinking and shrinking. Frankly, they're just getting older and they are dying. But those policies have completely warped the market. In the long-term care business, that book of business is considered a toxic asset. Nobody will take it on. There is no company that is making money in the long-term care space. They're just trying to weather the storm to get to the point where we can actually have a real discussion and to appropriately price the products. Maryland also has a 15% rate increase cap. It is the lowest cap in the entire country. Your rate cannot go up more than 15% in a year. There are a lot of protections to be built in. Now, I'm not saying that it has solved the problem. It has not. And there are folks that are seeing premium increases every year. But the problem with this kind of approach is that it does risk making it worse. And we are right on the edge of insolvencies. Like I said at the hearing, I do not want to take the guarantee fund out for a test drive. Now, there might be only a small amount of Marylanders that are impacted by this bill and in this approach with the amendment. But it is a precedent that will be set and it will be expanded to other states in the country. And why that's important, why I know that we're only here to talk about Maryland, these companies don't just write in Maryland, they write across the country. And a cumulative increase in Maryland and in Virginia and in Ohio and in South Dakota will add up and will cause another insolvency at some point. That's what we're worried about. We want these companies to remain whole so they can actually cover the claims. Like we can go back to the beginning, once again, where they priced the company, the policies wrong. Like I always say, and you hear me talk about it a lot, and you're going to hear me talk about it later today in HGO, is that health insurance and long-term care insurance is expensive because healthcare is expensive. When they started pricing these products, the average nursing home annual visit was roughly in the $20,000 to $25,000 a year. It's now over $100,000 a year, average. Marylanders and Americans alike are living a lot longer than when we started to inappropriately price these products. There are a lot of factors that go into long-term care policies and why the prices have gone up. Like I said from the get-go, it is not an excuse, and it is unacceptable that these prices keep going up and up and up. But this kind of approach, I think, would make the problem worse.
I'm gonna ask, Michael Patty from the MIA. I'm gonna ask you first.
Yeah, sure. So the amendment that Delegate Stewart, introduced certainly makes the intent of the bill clear and narrows the scope. In the MIA's opinion, this is certainly a policy decision for you all. The only thing that, we think that you should at least consider is, this could be viewed as a cost shift from those over the age of 85 to those under the age of 85. Obviously in Maryland, a rate is capped at 15% increase. Carriers do ask for increases much higher, knowing that there is still a Maryland rate cap at 15%. Our actuarial team still reviews that rate. I don't want there to be a misconception that the MIA automatically approves a 15% rate increase. It does not. We do review the rate, and if it is actuarially justified, that's what the increase needs to be, and then that rate cap is at 15%. So, you could make the assumption that for those individuals over the age of 85 that no longer are susceptible to that 15% increase, it could be passed on to individuals, under the age of 85, and that's a decision, that this subcommittee will have to make. In terms of actual numbers, I'd have to get back to the committee. The data that we collected didn't focus on the 2005 year in particular, but there are, I believe, 11 to 20,000, somewhere in that range, policyholders, that would be, would fall into this 85 and over, and obviously every year from here out, a new individual, comes into the above 85. So something to think about, but ultimately it's a policy decision. The MIA is going to continue to review rates and make sure that they are actuarially justified. And our rate cap is still in place at the 15% for individuals that aren't over the age of 85.
Okay. Thank you, Michael. Delegate Karen Lewis-Young.
Thank you, Madam Chair. I have a question for Matt. Since this product line was introduced, how frequently do the actuaries review their assumptions that go into the model?
Thank you for the question, Delegate. So it's on a yearly basis. When the companies come in for their new long-term healthcare policies, they are actuarially justified on a yearly basis. I don't even think that we're actually talking about in this frame of this conversation about those policies. The reason that we're having this discussion is because of those legacy policies, which there are just a few of them left, but they're driving the cost for the rest of the industry. And they're not going to be actuarially redetermined every year because they are unlimited benefits for the duration of the policy. And that's the problem.
Okay. Delegate, you're on mute. Okay.
I just said thank you for the clarification.
Okay. What I would ask is that we not consider this bill today, but if I could ask the carriers to come back with an impact statement, because if there are between 11 and 20,000 folks in Maryland, and believe me, I understand all the other stuff about the impact nationally, et cetera, but I am committed to the folks in Maryland. If that 20,000 people is spread out over 10 different carriers or 20 different carriers potentially, then the impact to each company could be less. It could be small. So if this committee could get some kind of impact statement, would be nice if we had it next week, but we can wait another week. Just to give us that information would be helpful. And
Delegate Carlson, I promise you I will get every bit of information I can get to you as quickly as possible.
Great, thank you. Delegate Kelly, you had a question or a thought?
I love your idea of having an impact statement, and I just want to request, if Matt's pulling it together, that he also factor in the issue that Michael Patty raised about the potential cost shifting, because that is of concern to me.
Yeah, so that is exactly
right.
I can tell you right now, I don't need an impact statement on that one. If the rate increases are limited to a certain age group, the rate request that would be added for the 85 plus will just be moved down the age scale. So your folks that between 65 and 75 are going to see a premium increase request that is going to be large enough to figure in the folks that they can no longer increase the price on. It's just the way it goes.
So in fact, the older folks who were able to get into these legacy policies that pay unlimited benefits would have just such a profoundly better marketplace than the younger, older folks now. Is that what I'm hearing?
Yeah, you will see folks that did not buy the legacy policies that will see their premiums go up because they'll be caught in the actuarial nightmare that this sort of marketplace presents itself to.
Thank you.
Thank you, Delegate. Delegate Stewart, did you have a response here?
Yeah, thank you. And I didn't know, I don't know what your procedures are. So sorry if I'm sort of speaking out of turn.
Waving's fine.
Okay.
I saw you.
Okay. Yeah, I mean, I think that certainly I'm also concerned about this idea. And I've of course thought of it, you know, the last thing we want is to put more burdens on, you know, seniors who are on the verge of retirement, who've been disproportionately affected by the pandemic, you know, to benefit older retirees. But I think, you know, the impact statement will be interesting. But in my view, you know, the seniors who have had these policies, these legacy policies, yes, their benefits are sizable. You know, they have all these benefits. However, few of them are much younger than, say, 80, because the average age that someone purchased a policy is usually in their 60s. And if we're limiting to people who purchased a policy prior to 2005, there are going to be few of these folks with legacy policies who will be under 85 who will be hit by any sort of cost shifting. And so I understand, yes, that people without the legacy policies might be hit, you know, harder, and the cost may be shifted to them. But I'm hopeful that, you know, as Mr. Celentano mentioned earlier, you know, these are nationwide companies. States refuse premium increases of, say, for example, I think Massachusetts refused a premium increase a couple of years ago of 164%, which is obviously was a huge shock to Genworth, the one in particular insurer who had to shoulder that cost. They appealed, they lost the appeal. And so I think that, you know, even on an individual company level, there are larger shocks to their system all the time than just focusing on this very narrow. And I think that 11,000 to 12,000 number, if I'm not mistaken, that Mr. Patty mentioned, I think that refers to people just in general who have these policies that are over 85, and not necessarily people who purchased policies prior to 2005. So I'd be curious to get those numbers. That could even be less than 5,000. So anyway, in conclusion, I'm hopeful that once we get the impact statement numbers, I would just be frankly shocked if this narrowly tailored bill would mean that a sizable number of Maryland seniors with different non-legacy policies would be paying much more.
Delegate Paul, can I make two contextual points just for the benefit of the committee? Okay. Very quickly. Just because a company is big doesn't mean they're not vulnerable to insolvency. And Genworth is an example of a company that has had to get capital from all kinds of places to remain solvent. Penn Treaty is not a small company. It was a multinational, huge company that went insolvent because of long-term care. The other side of it is that a lot of the folks that bought long-term care, and this is just to keep in mind as you deliberate these kinds of discussions, is that when folks bought the long-term care policies that had the unlimited benefits, you might have been 55, 60, whatever, it doesn't matter. The vast majority of those people didn't use the benefits until they hit a certain age group, and then they get really sick, and then they eat up all the cost. So it doesn't have to be over the course of the entire policy. It can be within a year or two. But that year or two of healthcare spending is driving up the cost for everybody else. So to be in mind, like when we're talking about the 85-year-old population, this is the folks that are spending down all those premiums. So it's really important to keep that in mind as we talk about this in the future. Thank you.
Okay. Michael, you're going to get the last word today.
Sure. I just wanted to make one point, just exceptionally clear. As we discuss cost shift, since Maryland does have a premium rate cap at 15%, if there is cost shift down the way, those policies may already, those plans may already be asking for 50, 60, or 70% increase. Our actuaries say 15%. Or lower, is what's approved. That cost shift, may not actually materialize because those policies have already been, receiving the 15% increase. I just want to make sure that's included in the conversation, that there may not be, because of the rate cap, the ability to just absorb, a policy that doesn't have an increase to now having an increase because it's been met at that 15% limit. So just something to consider. as that's discussed.
And so just so I'm clear, then that cost that can't be actualized in the rate increases then goes back to the company, right? That it's their burden then. Okay.
And I guess I was untruthful because I'm not giving you the last word. I'm going to take the last word and say, first of all, I appreciate Delegate Stewart, your effort to figure out how to do this. You have been a terrific champion here. But I would say the folks who bought the plans before 2005, I know they're using it at great amounts, but they've also paid for the last 25 years, and their rates have more than doubled since 2000. So it's not like they haven't put the money in, and that they haven't been contributing their fair share. And I think we just need to keep that in mind as we consider this. So we'll come back on this bill. And thank you all very much for your patience. And I hope everybody gets lunch before the Health and Government Operations Committee begins its hearings at 1:30. Thank you all very much. Take care.
Thank you.